Excuse me.
Just please introduce yourself.
My name's Clint Brass, and I work at the Congressional Research Service. And my question is not from the Congressional Research Service, so this is just me talking. I wonder if there are some learnable lessons from the field of medicine here, where you have evidence syntheses that get done, but there is a translation mechanism. And in part, we depend upon doctors to help with that, taking lessons elsewhere and trying to decide if they apply here to this patient with these comorbidities and problems. And one of the things that I think I was hearing as a theme was that brokerage, they use that term in the evaluation field, translation. I wonder if there might be potential there. Like, for example, for Congress often relies on GAO and my agency. So question for everyone, particularly state and local folks.
So we don't have the capacity to go create evidence everywhere, so we have to use the evidence that's available, that's been tested and proven. So turning to WISIP or turning to reports, national organizations that we're all a part of, APHSA, NACHO, NACO, all of these. I mean, it's multiple entities that you're reading journals, reading reports, getting information, and then going to national conferences where you run into peers. I mean, peers play a very important role in our lives. The way we built the calculator was, a colleague of mine was doing it in prisoner reentry, and I was like, wow, that would have such value for us if I could bring it here. So I think we do all of that. The question of if Mrs. Smith is walking in the door, what's the menu of services that we have in our toolkit to offer her? Often depends a little bit on resource capacity. It depends on, because you can't just bring an evidence-based intervention, right? You have to worry about fidelity. You have to make sure that you have the capacity, you have trained people to do those things. Like, for example, we're getting a large influx of unaccompanied minors who are fleeing violence in Central America. We know that trauma-informed care for children is pretty much benchmarked as the way to intervene for children who've experienced this level of trauma. How many providers do we have who are trained in trauma-informed practices? How many of them are bilingual? What's the capacity to serve? And then how much fidelity is there in the way they're implementing those services? All those questions get asked, and how much capacity we have to answer those questions is part of, I think, the journey that we have to take each time we're putting something like this into place.
I'd respond from a broader perspective. Systems matter. You mentioned health. Medicaid has overtaken education as the largest expense for states in the past couple of years. But as I explained to my friends from other countries who don't understand our system of federalism here, Medicaid is a joint state-federal program. The federal government pays a little over half of the costs, but the federal government sets all of the rules. And so when you look at Medicaid, and for that, it's true of Medicare and most of our healthcare system, it's still a fee-for-service system. So if you're looking for opportunities to save, the system really isn't conducive to that. And quite the contrary, the system almost promotes doing more tests, using more expensive procedures, because you get paid for the tests and the expensive procedures. Health isn't yet, maybe we're making some modest efforts to move towards it, but isn't yet an outcome-based, where you get a certain amount of money to produce, say, an outcome, and you try and promote the production of that outcome. So we had a speaker to the governors a year or two back from New Jersey who was looking at the high utilizers of health, and he saw that an awful lot of visits to the emergency room were for asthmatics who either didn't have their inhalers, or it had broken or run out, or very simply, in the summertime did not have a $99 room air conditioner. And he did some studies, and with some help from foundations, found that the purchase of $99 room air conditioner saved multiple $3,000 visits to emergency rooms because of an asthmatic attack. Let alone having visitors to the, this is particularly elderly, to make sure that they had their inhalers, or sometimes kids, to make sure they're having inhalers. A small amount of money would save a whole ton of money. And this was even in the same year. You didn't even have to cross years. But the system wasn't conducive to produce that result. So here we had some, as you correctly point out, we're getting more evidence in the medical area how to save some money in what is not just from the state, but from the federal perspective and from the national perspective, by far our largest expenditure. But our systems aren't conducive towards promoting effective use of those savings. So I would say that that there has to be a consideration of how to evolve our systems in order to help save that money.
Okay, any other public questions? We're just about out of time. Okay, so I'd like to thank our panelists, including Henry and Eric on the phone. I'm looking skyward at you, even though that's not where you are. So thank you so much for your time and for sharing your insights with us. And I believe we have an intermission, and then we'll be back for the second panel.